have two wonderful speakers who work in this area, bringing together public health and bioethics. First, we're going to hear from Ron Bayer and then from Harriet Washington. Ron is a professor of public health here in the School of Public Health. He is the co-director of the Center for the Study of the Ethics and History of Public Health. He's one of the leading people in the world working on public health ethics. He has written many, many articles for the New England Journal of Medicine, for JAMA, and for other major scientific publications. He's also written an important series of books, starting out with Homosexuality in American Psychiatry, looking at the politics of diagnosis. He then wrote a wonderful book, about AIDS, several books about HIV. One was Private Acts, Public Consequences, AIDS and the Politics of Public Health. He wrote a book with me, Mortal Secrets, Truth and Lies in the Age of AIDS, but he's also written books that are oral histories of doctors working on HIV, both in the US and abroad. He's written books on the politics of tobacco in this country and other works as well. After Ron speaks, Harriet will speak. Harriet is the author of Medical Apartheid, which won the National Book Critics Circle Award and was a New York Times bestseller. It won several other awards as well, as for instance, a Penn Award, and she's received numerous honors. She has been a fellow at Harvard in medical ethics, also a fellow at Stanford working in medical ethics, and we're delighted to have her as part of our faculty now teaching a course on journalism and bioethics. So. People are welcome to ask questions. We're going to have each of them speak for a little while and then have a Q&A. People online, please feel free to email your questions and we'll be answering them as well. So without further ado, please join me in welcoming Ron Bayer.
Good afternoon, and you ought to be praised for coming out in this lousy weather. Is this your cell phone?
Yes.
I will you're not a large group, and I think actually the most important thing we can do today is to have an opportunity for you to ask questions, both substantively about what you hear us talk about, and also about what this joint relationship would look like. So I want to say something about public health and public health ethics. So in the 19th century, what we now think of as a domain of public health emerged in the early part of the 19th century, and even before the term public health was coined. And from its very beginning, public health had two missions. The first mission had to do with the enhancement of population well-being. The second, which grew out of the concern about population well-being, was a concern about how social inequalities produce disease, and as a consequence, in fact, have huge impacts on well-being of people. There was a very famous book called The Condition of the Working Class in England by Engels. There were historical figures, all of whom tried to map the pattern of disease against patterns of inequality, with methods which would now be considered a little primitive, but nevertheless, the message was the same. Social inequality leads to patterns of health inequality, which leads to population ill health. So the notion of public health ethics, although there's always been kind of an ethos of public health, that is the values that inform public health, one having to do with notions of equity, and another having to do with utilitarianism, that is the greatest good for the greatest number, sometimes reinforcing each other, sometimes in tension with each other. But an explicit ethics of public health did not begin to emerge until the early 1990s. It was driven by two critically important social factors. One, of course, was the AIDS epidemic, and how AIDS forced people in the United States and Europe, before attention shifted to where the epidemic was really ravaging, that is, parts of Africa. So there was a sense, though, that there was this epidemic, and that the kinds of values one had to have in order to understand what an effective ethical policy would look like was very complicated, because the history of public health was not a history of being concerned with issues of individual rights, etc. In fact, the history of public health is really the history of the use of coercive mechanisms for public health ends. We may see some of those instrumentalities as always negative, or we may see them as having been necessary given what was available. But I think it's important to understand that an ethics of public health emerged at the very same time that the notion of human rights in public health emerged, in trying to deal with a sexually transmitted disease, a disease transmitted in the most intimate of contexts, and a disease which at the same time, and therefore touched on privacy, but at the same time was having huge impacts on the blood supply, was having huge impacts on the patterns of morbidity and mortality among young men. So the sense was that whatever tools people had in ethics was inadequate to confront the challenges posed by this new infectious disease threat. The second piece of the landscape that shaped a need for an ethics of public health was a recognition that non-communicable diseases were really defining, aside from the challenge of an infectious disease like AIDS, in Western advanced industrial countries, non-communicable diseases were driving patterns of morbidity and mortality. And the question of how to shape social behaviors that led to these patterns of morbidity and mortality could not be answered solely with the tools we had inherited from bioethics. Now, Bob speaks about synergies, but the truth of the matter is bioethics emerged out of an encounter with a clinical relationship. How should doctors act? What should they tell their patients? What rights do patients have? Who should decide? How do you define death? What about the early days of genetics? So there was that part. But there was also the part dealing with the scandalous recognition of what happened in the context of human subjects research. Out of these confrontations with clinical medicine and human subjects research, there were a core set of values that emerged: autonomy, the rights of the individual, building on social movements around women, around gay people in the 1960s. Notion of autonomy, anti-paternalism, which said basically that doctors may know their medicine, but they do not know best when it comes to making a decision about what to do about a person's life. There was some concern about equity and justice, mostly in the context of research. Interestingly enough, I think bioethics paid really only secondary attention to the patterns of social inequality. If one weighed the number of articles about anti-paternalism or autonomy, and the number of articles or books or courses focusing on social inequalities in health, the imbalance was clear. And that's why the need for public health ethics emerged. But even as people began to kind of address the issue of what an ethics of public health would look like, the reflection of how ethicists were imbued with this notion of individualism became very clear. So a leading individual in the history of bioethics was someone named Edmund Pellegrino. And this is what he said when people began to talk about public health ethics. Involuntary and coercive measures must be undertaken with a clear perception of the dangers they pose to a democratic society. Loss of personal freedom to choose a lifestyle, dependence upon government to define values and concepts of the good life, and the imposition of cultural homogeneity. Involuntary measures also assume a benign, wise, and responsive government, something history finds singularly rare. Now, one has to locate this statement in the history of bioethics. One has to locate it in the moment when a statement like this was being made. But if you believe that you cannot conceive of a state that serves the interests of the people, you cannot conceive of a public health. There is no public health without the state. Nancy Cass, who was a little more temperate in what she had to say, she's still a very important figure in bioethics at Hopkins. She says, "It is in great part because such power is vested in public health by law that a code or framework of ethics designed specifically for public health is so very important. The need for a code of ethics of public health then might be viewed as a code of restraint." A code of restraint. So in public health, people were thinking about how to mobilize the power of the state to advance population well-being. And here, a very thoughtful individual whose work emerged out of bioethics is talking about, well, just let's wait. Let's wait before we march in. So what I want to do I have, how much time do I have? So what I'd like to do now is this is what I do in all students coming into the Mailman School of Public take a core curriculum. You may say it's lockstep, but it's a shared experience is the way I describe it. And in the beginning, they actually have 6 lectures on public health ethics, 6 lectures on the history of public health, and 4 on human rights in public health. So I always say to them, the most important thing to learn in ethics is how to ask the right questions. So I want to give you a flavor for the kinds of questions. I actually do this with these classes much larger than here, 200 groups of 200. These are the kinds of questions that I try to have my students think about. The first are going to have to deal with the domain of non-communicable diseases, social behaviors, etc. The second having to do with infectious disease, which is actually where public health emerged. And finally, a few questions about notions of justice and the idea of what the state owes workers in terms of occupational health and safety. So, if I was smarter, I would have had slides, but I'm not, so I don't have slides. But just listen to these questions and just try to get the spirit of what they suggest. So, in the context of non-communicable diseases, what are the appropriate limits of the state in a liberal society in regulating, restricting, or prohibiting behavior of individuals that lead to excess morbidity and mortality, but which in the first instance harms only those who are engaged in those behaviors? So these are not behaviors that harm others directly, although at a population level there obviously is an impact. How should the social distribution, the existence of a social class gradient for such behaviors, inform our decisions? Should we be impelled to intervene to protect those already at social disadvantage? Or should we resist such impulses because those at social disadvantage have the least power and the least capacity to resist the authority of the state? And think about this in terms of something like tobacco control, where we've moved from a situation where half the male population in the United States smoked in the 1960s, and now it's about 17%. But if you look at that in terms of a social class gradient, people with a GED degree in high school, about 35% of them smoke. If you look at people who have a graduate diploma, about 4 or 5% smoke. And the social gradient is stark. So the question is, how do we intervene now if we really believe that tobacco control is critical, other than answering that maybe we should shut down the industry? But any action we take now to improve smoking at a population level is going to be most important for those already at social disadvantage, but fall heavily on those at social disadvantage as well. 3, what limits should there be on state power to shape our desires and preferences in ways that limit the need to use explicit coercive measures? What is the relationship between informing people about risks, using the techniques of advertising, counter-advertising, so inevitably manipulative? What limits ought there be to the use of fear in shaping public health messages, if that's the way you really get through to people? And what about the process of denormalization that occurs in these situations? Does it inevitably lead to stigmatization? So is denormalization of smoking, where people hide when they smoke because it feels uncool or crude, it works. That's why people don't smoke. On the other hand, to the person who is denormalized, marginalized, it may feel terrible. And there are ethical challenges in drawing that balance. And finally, a core question here is what power the state should be used to regulate industries that produce products that by their very definition will result in more patterns of morbidity and mortality. We know that about tobacco. The question has increasingly been raised when we think about soda taxes, etc. Okay, so let me shift ground now to give you a set of questions thinking about infectious disease. And here I want you to think about mandatory vaccinations. I want you to think about the uses of quarantine. I want you to think about the requirement that people undergo tuberculosis treatment, not simply for their own well-being, but for the well-being of the community. So here are the questions that I ask my students to think about when they think about the ethics of infectious disease. Number one, what are the obligations of the state to protect us from the threat of infectious disease? How should we judge the policies and practices that are employed to provide such protection? Beyond the obvious question of do they work, are there limits to what the state should do in the name of disease prevention? And here's a conglomerate of questions. How much risk, with what degree of certainty, and what degree of severity justifies what degree of intrusion on medical privacy, restrictions on freedom of movement, for how long, under what circumstances, and for what number of individuals? And I'll just use one example. When there was a SARS epidemic that kind of shook the world several years ago, in the province of Ontario, a decision was made to impose a quarantine. It turned out, we didn't know what was causing the disease, but that seemed to public health officials the logical thing to do. It wasn't sending people away, it was a household quarantine. Shops were closed, businesses were closed. It turned out in retrospect that the quarantine was about 60% overextended. That the number of people quarantined was far greater than needed to be quarantined. Were they wrong to impose the quarantine when they were unsure, when they were uncertain? Would they have been fools not to use that technique? There's both an empirical question here, what is the evidence, but there's also a normative question. How do you act in the face of uncertainty? Who bears the burden of acting in the face of uncertainty? Who bears the burden of not acting because we're uncertain? Okay. Let me see. Oh, finally, what are the obligations of the state to create or secure the social circumstances that permit communities and individuals to protect themselves from disease? It's not enough to act to prevent the spread of a disease. If we know that infectious diseases are rooted in some way and spread in part because of social inequalities, what are we to do? Okay, the final set of questions I wanted to raise have to do with occupational health and safety, where questions of equity and fairness arise. One of the leading figures in bioethics, Norman Daniels, who wrote kind of extensively about the history of thinking about justice and access to healthcare services, dealt with this issue as well. So here are the questions one would ask, and you could ask them about environmental health as well. What ought to be the responsibility of government to protect workers from occupational hazards that emerge as a result of chronic exposure to workplace toxins? What evidence should be sufficient to justify regulation, and how should the burdens of uncertainty be borne? In what ways are those obligations similar to or different from the obligations we face in terms of environmental threats? Should the protective standards we adopt consider the risks of the average worker or the most sensitive worker? And should workers ever be able to bargain their security and safety from exposure against better wages if they could make those trade-offs? Would those really be free trades? Or would they be so coercive that regardless of the fact that they chose under circumstances which were so situationally coercive? I'm going to run out of time. So let me just say that within the world of public health, I think it is fair to say that the following statement by a philosopher named Robert Gooden, who's a utilitarian, who wrote a really wonderful little book about tobacco, this is what Gooden said. We do not leave it to the discretion of consumers, however well informed, whether or not to drink grossly polluted water, ingest grossly contaminated foods, or inject grossly dangerous drugs. We simply prohibit such things on grounds of public health. The fundamental point is to promote the well-being of people. That is the utilitarian measure, and this is there are obviously voices in opposition, people who cite John Stuart Mill and the harm principle and on liberty, but the point is that the point I want to make is that while in bioethics, paternalism was seen as the bad guy that had to be confronted, and only under the rare circumstances was paternalism justified, in public health, versions of paternalism were the default, and overriding the paternalistic goals was seen as requiring a heavy lift. So let me just say one thing. I think I've run out of time, but one thing. In the effort to create an ethics of public health, which I said is very recent, there's no clear formulation the way there is in bioethics with the Belmont report and whatever. And so it's new, and the language is new. But I think it's fair to say that there's a consensus around the following notions. The first is that the goal of public health ethics is to require of the state that it act to advance population well-being. That is number one. Number two, it was the obligation of the state to consider social inequality as it looks at the pattern of disease and also as it thinks about the burdens created when it acts to prevent disease. Number three, respect for persons. Now, this is the standard stuff that emerges out of bioethics. The point I want you to note here is that respect for persons isn't number one. It's there, but it's there in the context of the first obligation, which is to protect population well-being. And finally, people working in public health ethics have talked about good governance. What process is used to make decisions? All these trade-offs I've talked about. Who's represented at the table? How open is the discussion? How honest is the discussion? How open to new data is it? These are very important things to ask at the current moment when we live under a regime that is sort of data-free. And I say this with great, great seriousness because we have never been at a moment when the role of evidence and the burdens of that we see around us have been so disregarded. And I think it's fair to say that the current government in Washington does not believe in public health. The last thing I want to say, and I'll step down, is that if you believe that public health is intimately related to issues of social inequality, and that just inequalities are not inequalities, they're inequities, they're unfair. If you believe that, then one has to ask the question, what does it mean to live in the United States now when the level of social inequality is deeper and steeper than it's been for 100 years? Can you really have an effective public health? It's not just the 1%ers. It is the whole distribution of income and wealth in the United States. There was a report issued by the National Academy of Sciences 3 or 4 years ago that compared the United States to about 17 other advanced industrial societies. We were at the bottom of the heap. Not the middle, not near the top, the bottom. On everything from childhood stuff to adolescent stuff. The only people who weren't at the bottom were people over 75, thank you, because they had made it through. But for the rest, the picture was dismal. And I think one has to ask oneself, what is the impact on public health, and not simply public health, but the world in which we live, to have such enduring patterns of social inequality? And I think I'd better stop now.
Well, thank you, Ron. That was great, and I think you did a wonderful job laying out a number of issues, and clearly issues, ethics and politics and everything else that affects our lives. I would just say, by the way, my own perspective is that bioethics as a new and evolving field is a broad one, and that whereas before there was clinical ethics, there was medical ethics, bioethics is broad, and one of the 3 principles of the Belmont Report is social justice, and many of us and many people in bioethics increasingly take social justice very important as one of the main pillars. So many of us see there are many now subdivisions or subsets of bioethics. There's clinical ethics, research ethics, neuroethics, reproductive ethics, and public health ethics. So I see public health ethics as fitting within the broad rubric of bioethics per se, One can define bioethics in different ways, but I see it really as a broad tent. So thank you. And we're delighted, as I said, to have our next speaker, Harriet Washington, and please join me in welcoming her.
I learned a great deal from Ron Bayer's talk. Thank you for that brilliant praises of public health in relation to ethics. However, my take on it is a bit darker, I'm afraid. The fine documents and legislation that have been evolved sometimes and in some groups are honored much more in the breach than in the observance. And that's something that is very important for a marriage between public health and ethics, because it desperately needs that ethical input to more closely examine practices and policies that have become quite common but are not always well analyzed from everyone's perspective. One of the things, I'm not going to have time to actually dwell on every slide. I'll be doing well if I can just sort of briefly touch on it, but you can read it for yourself. And my main gist here is that the canon of public health, like the canon of medicine, is incomplete. It ignores entire populations, and in particular, it has ignored, in large part, the contribution of African Americans. For example, if you think about smallpox eradication, and even the earliest attempts at it, it is the work of white physicians that is honored, but in this country, it was an African slave, Onesimus, who first showed Cotton Mather how to do a smallpox variation, and in the consequence of that, saved the city of Boston in 1721 from a smallpox epidemic. These are the kind of stories and information that need to be part of the canon, so that people will understand that marginalized populations have played a role not only as recipients of medical care, but as originators of it. It will make a huge difference in many, many ways that I don't have to detail for you. You can only imagine them. Another aspect of public health is that, I apologize for all the writing on this slide. I think I had actually taken some of it off, but it didn't take, I suppose. I'm not going to read it anyway. My main point here is that my latest book focuses on the effect of environmental racism on IQ and intelligence in this country. Now, there are many, when you look at the clear evidence and the increasingly precise evidence showing that these exposure to poisonous heavy metals like lead, arsenic, mercury, pathogens, chemicals that are largely in this country, unlike the EU, unregulated, disproportionate exposure takes place that is racially mandated, not by socioeconomic group. Recent studies have shown that, for example, African Americans with higher incomes are more likely to live near toxic dumps and sites of foci of toxic exposures. African American women who have PhDs and MDs are more likely to suffer fetal distress as a result to exposure to these things. So it's a racial problem. However, also food swamps. Some people say food deserts. I understand their point. You don't have a supermarket, so you're reliant on McDonald's, et cetera, for your diet. But these areas have not only poor food and horrendously expensive quality food, they also are rife with alcohol, saturated with alcohol and tobacco, sometimes in forms that cannot be easily found in the mainstream. So all these exposures create an ethical nightmare that is largely unaddressed. In discussing IQ, when people talk about IQ in this country, you often get this traditional bewailing of the 15-point IQ gap between black and white Americans. And well-minded people say, what can we do? How can we fix it? People who are not so well-minded say, nothing can be done. It's genetic, they're born with it. Don't even waste our resources on things like Head Start, it's not going to fix it. But they're wrong, because in 1924, we resolved a similar 15-point IQ gap by a simple, cheap step. We added iodine to salt. We did not know that iodine deficiency was a major cause of mental retardation. We were trying to fix goiters. We were trying to resolve goiters. And so low iodine areas, people got iodine from their salt, and goiters disappeared, but the IQs also went up, showing for the first time on a very large scale that addressing environmental issues can go a long ways toward increasing intelligence and resolving the IQ gap, something that we need to explore more, and something that needs not only medical epidemiological attention, it needs ethical attention. Here's this one note about the role of pathogens. There are several scholars who have looked at and tracked the role of countries, including areas, ethnic enclaves in this country, where there's a high density of pathogens that are known to erode intelligence in fetuses whose mothers are infected, and they find a very close correlation. We also have a lot of issues with pharmaceuticals, and one of the things that always fascinates me is the tension between medical research and the knowledge base of everyday people. So everyday people, of course, are concerned about things like their very expensive medications, and they're placated by the industry, which tells them, oh, well, they have to be expensive because we're spending so much money. We're spending $2 million for every new pill we generate to devise these medical miracles. It costs a lot of money, except it's not true. And we know it's not true. An analysis done by Merrill Guzner in his book, The $800 Million Pill, showed the way data has been tortured in order to make it appear as if these industries are investing a lot of money, when in reality, it's your tax dollars that are funding development of new medications. So you end up paying for them twice, through your taxes and when you buy the overpriced medication off the shelf. Now that means, of course, in this country, unfortunately, people go bankrupt trying to pay for their medical care. But in the developing world, people simply die. There, the drugs are priced out of their reach, or may not be there at all, because the companies have realized that the market does not exist for the drugs. So these kind of things are very often discussed in newspapers. They're very often discussed from a medical point of view, but the ethical conversation, I think, would be enhanced by a public health perspective of the type that Ron has so ably laid out for us. We also have a new development in the what I call the erosion of informed consent. But you might look at it a little more sanguine way and say that we simply are beginning to accept medical research sans informed consent. Sans consent of any kind in some matters. And again, the discussion in medical circles, discussion in policymaker circles and pharmaceutical circles has been focused on what's called emergency research. They're focusing on the rationale for it, which is of importance to them. But what's important to everyday people is the fact that I might be in a medical trial and nobody has asked my permission. So the problem is that this emergency consent was made legal in 1996 by an amendment to the Code of Federal Regulations. You can look it up. And it posited exceptions for unconscious trauma patients. And it lays out criteria that have to be met. Unfortunately, the studies that were actually done under that and continue to be done tend to violate these criteria often. And I've written about this, no time to go into detail about it now, but I've written about this in my book, Deadly Monopolies, and I'm working on a new book published by Columbia that is going to deal with informed consent erosion. This is a serious problem that's not getting enough broad attention from a public health standpoint. And the rationales are rationales that make a lot of sense to trauma surgeons trying to save their patients, and make a lot of sense to pharmaceutical companies who are trying to devise new medications and don't want to invest in the time and effort needed to garner consent. But they don't make a lot of sense to Americans, and worse, many Americans, most Americans don't even know that it's happening. Oh, as a nasty grace note, at least one of the studies I've looked at, from the company's own data, from Northfield Laboratory, you can see that most of the subjects enrolled in this study that did not give people opportunity to give consent to the study of artificial blood, most of them were people of color. Just a few popular pieces I wrote about the increasing elision of consent, or at least informed consent, from medical research. And then some of the interesting, as a person who studied literature, I'm really fascinated by the semantics of all this. The language has been very ably twisted and tortured to utilize the word consent in scenarios that have no whiff of consent, that have no consensual. So this is something, again, that deserves scrutiny in a public health context. And utilitarian is something that Ron talked about. It's a very important concept. Talk about it frequently, but one of the things I find really interesting about utilitarianism is that it's something that Jeremy Bentham championed as a young man. As a more mature scholar, he talked about something else that I find really important and really underaddressed. And that he talked about futility. And the way he talked about futility was to point out that impossibility is often posited as a reason for not taking action. This is true in the medical sphere as it is in the legal sphere. A good example was a 2014 Ebola outbreak. I frequently heard, and I argued on CNN with someone who was, actually most people were claiming that we simply can't give Africans ZMapp. We simply can't give them the new medications. I mean, we can't afford to medicate the entire third world. We'd love to help them, but we just can't. Futility, the plea of impossibility. But Bentham went on to say something else. He said, first one creates the impossibility, then you plead it. And that's exactly what happened here, because my response was very simple, layperson's response, which is, we don't have enough ZMapp for everybody, make more, you know? And for people who consistently claim that the expense of treating people in the third world means that we can't do it, I suggest that we owe them. That we're in their debt, they're not in ours. And we're in their debt because they have become the laboratory of the West. It's more now, it's 4 out of 5 clinical trials by pharmaceutical companies are now conducted in developing world. 80% of approved modalities are now have been tested in the developing world. They've become our laboratory. And although our rationale is often that we're testing something that is a huge problem in this country. We're testing thalidomide against leprosy, because leprosy is a huge problem in Brazil, for example. But what happens when the modality is approved and on the shelves? Are these people the market for the drug? No, they can't afford it. Probably the most dramatic example is the sleeping sickness. There was a medication, eflornithine, that was found to be a wonderful innovation, a perfect cure for sleeping sickness. It brought back people who had been unconscious, who before that could not be brought back, and it was called the resurrection drug. It worked really well for a while, but then the company withdrew it from the market because Africans could not afford to pay for it. But I found a few months later that you can get eflornithine, you can still buy it. You know where it is? It's in a cream sold to middle-aged women for removing facial hair. Look on the tube. The primary active ingredient is eflornithine. That's a sleeping sickness drug. So Western women who can pay $50 a month to have their facial hair removed can buy it. But people with sleeping sickness in the developing world can't get it unless a group like Doctors Without Borders intervenes, or at one point Aventis, to their credit, did make it available at very low cost for a while, the kind of thing that we want to see the industry do more often. But again, what I found really interesting is I read most of the descriptions and analyses of this in journals like that dealt with health economics, that dealt with research questions. One didn't read about it as broadly as I would have liked, and the ethics of it were not analyzed as broadly as I would have liked. And of course, big data is powerful tools, a whole swathe of new tools we can use in medicine. But of course, one of the big ethical consequences has been the reification of race. And I gave them a couple links here where you can read more details about it. But the short version is, the problem with the data is the old adage, garbage in, garbage out. You amass a huge amount of data, but if what you do is if you put it through the same filters that you used in analyzed data in the past, which was clouded by racial mythologies, you're going to get the same garbage. For example, you have a huge amount of data and you decide that there's some genetic signature that particularly relevant to African Americans, and you look through the lens of genetics. The problem is that genetics often, in fact, tends to map very poorly onto race. So you end up with a lot of data which you think characterizes racial profiles, but it doesn't. You've got genetic profiles that may not actually apply to race. Still, we're very vigorously applying them that way. And a workshop that I did with Dorothy Roberts at the Brochure Institute is online still and is worth taking a look at. There were 12 scholars, 6 from Europe and 6 from the US, who talked about different aspects of this, the reification of race through big data. And I want to wind down pretty quickly, but one of the other things I want to talk about is that part of the ethical discussion that I have seen actually take place more in a public health setting than in the medical setting is the question of receptivity of populations. Ron alluded to it very ably, and I think that there are a lot of mythologies about marginalized populations and their history. I mean, for example, you often read about people who are afraid to engage with the medical system because of past abuses, but with no proof that these abuses are confined to the past, because they're not, unfortunately. And also, one hears a terminology like non-compliant and paranoid, but it's not paranoid to have a substantiated fear of abuse, based on things that have actually occurred. So, and also, I also want to make a plea for greater awareness of this. I look at the title of papers like this, Use of Placebo Controls in Life-Threatening Diseases, something that has fallen out of favor in the West for good reason. Is a developing world the answer? What kind of message does that send to anyone who advocates for or lives in the developing world? So we have to be, very, very careful to, even though the Helsinki Declaration, unfortunately, one of these great documents, has been modernized in a way that has reduced protections to people in the developing world, even so, I think we still need to strive to make sure that people in Gabon receive the same dignity, autonomy, and beneficence as people here people in Connecticut. Thank you so much for listening to me.
Well, thank you. That was great. 2 wonderful perspectives on these issues, and we're delighted to open the floor up for questions. So, people in the room or people online? Yes, please. Yes.
We can face our interrogators.
David.
Ron, you talked about the ethical implications of coercive force being imposed on populations in the public health context. And I'd be interested to know what you think the ethical limits are of coercion. Is there good coercion and bad coercion, or is the negative impact of coercion simply a matter of the power that stands behind the coercive process or the coercive influence?
I think in public health it is pretty clear. I mean, people don't like to use the word coercion, but we have, one of the classic cases is mandatory motorcycle helmets. And the justification for those helmet laws when they were first enacted was that people create cost to others because they smash their heads in and then they get picked up by ambulances and then they have disability and blah, blah, blah. The real reason those things were enacted was to protect motorcyclists themselves, but we couldn't say it because it sounded too paternalistic. But the most remarkable thing is that there was a time when every state but one in the United States had mandatory motorcycle helmet laws, and now half don't, because of the triumph of a notion of it's my body, it's my thought. Some states have no regulations. Most states say regulations only apply to adolescents. I think it's very clear that we require people to take their TB medication if they decide not to take it. We don't say it's your choice. We even require people to take TB medication when they themselves are no longer infectious, which happens very quickly in treatment, but because they're not yet completely cured. There have been many abuses of quarantine, but there's certainly moments when quarantine is justified, when the individual is both victim and vector, which is the title of a wonderful book by Peggy Batten. So I think the question one always has to ask is, those set of questions I ask, what's the risk you're trying to control? I think coercion in the face of flu seems a little crazy. On the other hand, I work at an institution where if you don't get a flu vaccine, in flu season, you have to wear a mask. It's like wearing a big letter A on your head, it is, but I think it's justified. And I actually think of an argument could be made that if you're going to be a nurse or a doctor or a health worker in a place that's treating vulnerable populations who will die from the flu, you don't have a right to walk in on, flu vaccines aren't 100%, but there's no right to expose others in this kind of way. But I think one has to kind of, think through the tensions. And I think clearly, the history of quarantines in the United States against Chinese immigrants on the West Coast, where the evidence was virtually non-existent, the use of coercive measures in dealing with and I think, Harriet, you're absolutely right. I mean, we allied in a way that's very problematical the issue of race and class. There are, and the data you showed about women with higher education, black women, suffer consequences during childbirth that can't be explained by class alone. So in a country that has a history of racism and racial abuse, we have to look at both. And I think we don't do so so there's no easy answer, but I think the bottom line is depending on the threat, depending on the nature of there's a difference. I don't think anyone who's quarantined should be quarantined at Rikers Island. I think people who are quarantined should be quarantined in a hospital, a real hospital, or at their homes. My wife this is a funny story, when I'm pretty old, and my wife is a little older than me. She reminded me when she was a kid growing up in Cleveland, she had scarlet fever. And there was a thing posted on her door warning all the neighbors that someone with scarlet fever was living in that home. She was restricted to her bedroom by her mother and father. But we did those things. Were they wrong? I don't know. I don't know enough about scarlet fever. But, and we have the anti-vaccine people who kind of create cockamamie arguments about mumps, measles, rubella vaccine creating autism. It's just not true. But it's an argument, it's a right-wing libertarian type of argument that basically does not believe, that doesn't believe in collective goods are possible. I better shut up.
So Ron, you mentioned, by the way, to turn back to some of the questions you posed to your classes about how to proceed in the face of uncertainty. So what would you say? How should one?
I think one has to weigh the consequences of not acting. I'll give you a very good example, which isn't the infectious disease issue. It's the current debate taking place about e-cigarettes. There's a considerable amount of uncertainty about, with the exception of the kind of people who think they know all the answers, a considerable amount of uncertainty about whether or not nicotine use in e-cigarettes actually does lead people who never would have smoked to use nicotine-bearing devices who then go on to smoke. We don't know the answer to that. We don't know the long-term consequences of the use of nicotine devices like e-cigarettes. But we do know what happens when people smoke cigarettes. 450,000, 500,000 people a year in the United States die from smoking-related diseases, and globally I think it's about 8 million people die from tobacco-related diseases. And that's not an uncertainty, that's a reality. So the question is, what do you do? And it is interesting to note that the British have embraced e-cigarettes, as a harm reduction device. Their national commission issued a report basically saying e-cigarettes should be available in the kind of little shops in hospitals. And this is the public health authority. And that for some patients who've been hospitalized for a long time, who are having difficulty, who are smokers, e-cigarettes should be available to them in secure rooms. So how is it that we have one database? How is it possible for people to interpret the evidence so differently? And the reason is the British are concerned about smokers. They're unsure what will happen to kids or whatever, but they're concerned about the people dying of smoking. In the US, the concern is not with smokers, but with non-smokers and kids. And so we weigh the uncertainty in a very different way than the British do. And the Australians have decided just to ban them. They're not available to anyone. So, and there is one issue that comes up in the environmental movement. It was started by environmentalists called precautionary principle. It says, when in doubt, a potential threat, even if the evidence isn't definitive, you don't let it happen. But precautionary thinking has its problems, and a guy named Cass Sunstein calls it the paralysis principle. Anyway, I'm sorry.
But you know, I'm glad you brought that up, because precautionary principle, of course, is embraced in the European Union, but not here. However, when you have industries like the corporations in this country who are dealing with 160,000 totally unregulated chemicals, many of which are suspected of directly causing human disease, to say nothing of the lowering of IQ and cognitive and behavioral disorders. But we don't test them until enough people get sick. When we find out that people are dying wholesale, then we test them. It seems to me it makes more sense to test them beforehand. That's also a precautionary principle. And people will come, and then I hear people say, well, it'll be expensive. It's expensive treating these sick people as well, you know? And it's not a matter of dollars and cents. We're talking about our nation's future, you know? 16 million lost IQ points to chemicals that were never tested here but were tested abroad and can't be used in France, for example. So I think that's a really important point. Precautionary principle bears re-examination and also context, because I understand it's a lot easier to you know, exhort its use in the case of these corporations, which are clearly, you know, harming people by releasing chemicals you know, that are harmful. And it's a little more nuanced when you're dealing with, you know, e-cigarettes.
By the way, I have to say that although Bayer was mentioned up there, I'm not part of that family.
Yes, in the back.
Hello. So I was interested in those connections you were then bringing up to some of the international players. And I was wondering, when you think about this balance between autonomy and the public good, the individual and the collective good, the frameworks for thinking about that, what do they tend to be based on themselves? Like, do they tend to be based on the things that we really truly believe the state is and should be doing, and that drives, for example, the difference between the UK and the US? Or what do those frameworks look like?
That's a big question.
Yeah.
Why don't you start?
Well, one thing, I hope this is not too far afield, but it you know, puts me in mind of changes in public health practice and, I don't know, in theory in this country, where we've embraced personal responsibility to a larger extent, and at the same time no longer tend to confront corporations. It used to be that public health you know, schools and organizations would confront a corporation accused of, you know, somehow harming health, and then leverage it in many ways, including legal, to try to get it to conform to a behavior that's going to promote health. And it seems that the focus on personal responsibility doesn't work well in some areas. The thing that I'm most interested in right now, environmental poisoning. If you live in a fence line community near a polluter, you can't afford to leave. you know? You can't escape those fumes. You can't escape exposure. If you work in a community that is like, where it's like a company town, you have to work at that, then you can't escape, you know, exposure to that. So those are cases where personal responsibility doesn't make a lot of sense, you know, and it's certainly not promoting health because there's so little you can do.
I was just going to say one more thing to that question. I mean, the cultural context within which these ideas and how these balances are struck is obviously very important. And I think Anglo-American thinking is not the same as continental thinking. And I think if someone would try to launch a campaign around public health in the United States, focusing on the notion of solidarity, I mean, it just doesn't work here. In France, they get it because that's part of fraternity, equality, whatever, liberty, equality. You can't say fraternity, so you say solidarity. So it seems to me that the cultural context matters. I actually had a student from Switzerland once who said in her country, the question of motorcycle helmets was not about whether it was unacceptably paternalistic, but whether making people wear motorcycle helmets would encourage them to take riskier behavior because they thought of themselves as being protected. And so it was a very different kind of question that was being asked. But, you know, in the United States, mind you, when motorcycle helmets were required, every state in the union but one, the mortality associated with motorcycle helmets went like this. Despite that evidence, the laws were rescinded in the name of liberty, and it's been it's a perfect experiment which would be completely unethical to conduct, but it was an experiment imposed upon us by policy. Helmets protect, and we face the same issue, by the way, now with brain injury in adolescents and high school kids, and football, and for years the denial of. And the idea that every parent has a right to choose and whatever, and don't you impose on families. And I think it's very hard to use the language of collectivity in the United States, except in wartime. And I think that's a problem in a field like public health, where the notion of the collective is so central, it poses real problems.
So I would say historically what happened, I think after the Tuskegee syphilis scandal actually, Congress in 1974 passed the National Research Act and asked people to come up with what should be an ethical framework for dealing with these issues. And of course the problem is that when a lot of ethical frameworks were developed in the past, be it the Ten Commandments or the New Testament or Plato or Aristotle or John Stuart Mill, we didn't have the scientific phenomenon we have now of clinical trials, of treatments for various diseases that may or may not be affordable or available. What do we do with these issues? And so this is when the so-called Belmont Report was written. Belmont was the place where they wrote it, where a group of people who came together and said, well, here are 3 principles at the time: respect for persons, beneficence, and also social justice. So that's and of course they were drawing on, implicit in that is work by John Stuart Mill, by Jeremy Bentham, by Aristotle, by others, etc. And I think the exciting thing about thinking about these issues is these are clearly very important issues that are affecting billions of people all over the world, but this is an area that needs thoughtful people to think through, how do we weigh these? How should we weigh these? Are there other principles? How do we interpret these principles? How do we apply these principles, et cetera? How do we rank them, weigh them in different situations? How do we enforce these principles? Thank you. What do we do if the political regime is not valuing these issues? How do we use force of moral suasion? How do we convince people to be more enlightened, if you will, et cetera? Yuki, you had a question.
Hello. So Dr. Washington, you mentioned that 4 out of the 5 drugs tested in developing world are not brought to
By pharmaceutical companies, yes.
They don't end up being in the market,
There 4 or 5 are tested in the developing world, is what I said.
Right.
Yeah.
So I wanted to ask, if you had any suggestions of some policies that can be placed, or measures that can be taken by
absolutely.
to ensure that the developing world can take advantage.
Sure. We've made several modifications. Declaration of Helsinki, we need to go back and remove them because a lot of them reduce protections. It once stated that you had to offer someone in one arm of the trial standard of care, which is what we do in this country. Then it was changed to say the standard of care in that country, which is often nothing in that country. So we need to change that. We also need to exercise more control over pharmaceutical companies. The argument is that these are private concerns. With capitalist society, profit is not a dirty word, it certainly isn't. But when you're a company that is conducting medical research or funding it, controlling the medical research in essence, then your responsibility should extend to complying with the IRB's requirements, complying with federal requirements. Today, all they ask is assent. They ask the researcher to say, of course I'm doing the right thing, but there aren't any checks and balances. There aren't any, any punishments. There isn't much oversight. And Bob's book, The IRB Police, goes into great detail about some of the challenges of actually enforcing these laws. In the developing world, you can multiply that 100-fold. And also, although profit is the right of these corporations, the fact is the initial research on these medications is done at universities for the most part, using our tax dollars, which I think should give us some say in which medications are and are not tested, are and are not devised. Why do we have 20 drugs for erectile dysfunction and almost nothing for malaria? That should change. And our government has a right to do that. We do have legal precepts like the march-in laws under patent law that let the government take the patent from a company that is not supplying medications and reassign it, but we don't like to use that. When companies like Brazil and Thailand do that, we call it intellectual theft and come out on the side of Merck. We did it for DirecTV, but we won't do it to make medications available to people cheaply in the third world. So that's something that should change. The government should be required to, I don't know how you require the government to do this, but the government pressure should be brought to bear. So the government will use these laws more frequently to make sure that people in the developing world who are testing the drugs that we depend on actually have access to them after they're found to be safe. So there are a lot of legal changes I think should be made to extend the protections that shelter us to the people in the developing world who are actually the bodies, the people who are making our healthy lives possible. Off my soapbox now.
I just want to say one thing, and it shows that people who deal with ethics can have disagreements. I remember the moment when the regulations around the trials was shifted to what could be the standard, and it actually was sparked by a trial involving AZT to prevent mother-to-child transmission of HIV. A regime had been developed in the United States and France that reduced transmission by 2/3. It required the use of AZT for 6 months, an intravenous dose after birth. I can't remember exactly, but it was thought to be undoable because it was too costly. People in South Africa who were involved in the anti-apartheid movement said, we need a trial that compares what is available here, which is nothing, that compares it to something less than perfect, but that is doable. That trial produced something called short course AZT. It had a huge impact on mother-to-child transmission, but it sparked exactly the debate you were referring to. And what's interesting, the people on either side, there were the Ruth Macklins of the world who thought this was just horrible. And then there was Bob Levine, one of the founding figures in research ethics at Yale, who was an advocate of this change. So we have to ask, a debate like this has to occur, and the implications of what a changed rule does, even if in that circumstance it made sense, does it make sense for others? I think those are the kinds of issues that serious students of ethics have to be able to have a conversation about, candidly and openly, agreeing to disagree. That's all.
We have time for one last question, but then I think our speakers will be around for a few minutes to answer other questions if you'd like.
Thank you very much. This is a great presentation. I wanted to get your opinions on what you think the role of bioethics has in framing public health policy and law going forward. I'm thinking, especially with our opioid epidemic going on right now, there's a lot of positive data in the UK about safe injection sites. However, when we talk about it in this country, we have immediate, I would argue, uninformed opposition to these types of public health interventions. And it seems that if we, employ bioethical analysis to reframe the role of the physician and the nurse and healthcare provider to, take it away from not, we're not having them participate. We're not having them participate or be complicit in drug use. Where they're there to save from overdose. They're there to increase intake in drug rehabilitation programs. They're safe injection sites keep dirty needles off the streets, and so you all these positive outcomes for the policies, and we can't seem to. It seems to me like it's a bioethical analysis of a lot of these health policies and laws is underutilized in the public advocacy realm.
The U.S. opioid epidemic is not new. It used to be called crack. It used to be called just drug addicts, those criminals on the streets. But now it's an opioid epidemic. And a more appropriate medical model is being embraced. But it used to be a punitive model. I remember 20 years ago having that exact discussion with Dimitris Trifakopoulos, who was head of epidemiology at the Harvard School of Public Health. And we were talking about needle clinics, which he was in favor of. He said we need to have these needle exchanges. We go to the communities where there's been a large density of drug addicts, and we set it up. They can get clean needle. And I said, a lot of the people in those communities don't want that. He said, well, they don't understand. I said, no, here's what we don't understand. The communities are filled not with drug addicts, but with poor people, working every day, sending their kids to school, trying to live, dealing with drug addicts in their area, trying to minimize the damage and exposure to their kids. Now you're proposing to have an exchange program where drug addicts and opioid users will flock to that area. Their children will see a needle exchange. It's not the kind of thing that the community wants. And if you want to convince them of this, you need to convince them of it before you put that clinic there, not afterwards. Otherwise, there are communitarian issues as well. So, you spoke about the healer's role, the doctors, nurses, very appropriate. Also, consider the patient's role and the role of the people who actually live in that community. So, with the opioid epidemic, it may be different. You may not be talking about a concentration on economic gradient. It's the same thing. It's a very different thing, but the principles still apply. You need to, communitarian concerns have to be part of this discussion, in my opinion.
Yes. That's a very good example of how what, from the point of view of people involved in thinking about efficacy, seemed a very simple, obvious answer. And when the idea of needle exchange was first proposed in New York under Commissioner Joseph, there was huge opposition in Harlem. And African-American doctors, they just saw this as a way of turning your back on the problem and normalizing it. Whether we agreed or not, it's important to understand, if you're going to have effective public health, public participation is crucial. And it demonstrates there may be a tension between a commitment to democracy and a commitment to doing that which is clearly evidence-based. And we have to think about how to balance those things.
And I would just say, and then unfortunately we'll have to stop, but we'll be happy to answer other questions afterwards, is one-on-one, is that there are questions of who is defining beneficence and justice and autonomy, and who is balancing these. And it certainly shouldn't be just people in ivory towers. It needs to be people who are affected, people whose lives are at stake, should also have voices in these conversations. Unfortunately, we are out of time, but clearly there's lots of issues we could discuss, and this is a wonderful sort of, I think, set of dialogues and cross-fertilizations that we look forward to having. And so please join me in thanking our speakers, and thank you for coming tonight.